Thank you very much. I will talk a little bit about post-operative pulmonary complication, no conflict of interest to be declared for this lecture, and a great thank, as usual, and a great thank to many people, because the data that I will present are the results of different larger studies performed by the prominent investigators supported by the European Society of Anesthesiology. And those of you who are interested in the activities of the prominent investigators can have a look at this website address. So first of all, morbidity and mortality related to postoperative complication. This is a quite large study performed a few years ago showing that those patients after abdominal surgery who develop a pulmonary complication, they have a major increased risk to die, up to 25%. And those patients after thoracic surgery who develop lung injury, they have a risk to die of almost 40%. So the first message is that if you develop postoperative pulmonary complication independently from the severity, there is a major increased risk of death. So it's a major problem. How to predict those patients who are more likely to develop a postoperative pulmonary complication? I will just focus on two important issues, so the use of risk scores and the importance of preoperative saturation, oxygen saturation in air. This is the ARISCA score. This is one of the scores. This was mainly studied by the group in the European Society of Anesthesiology. And this is a very easy score, which includes some data coming from the characteristic of the patients, which means the age, the preoperative oxygen saturation in air, respiratory infection in the last month, and the preoperative anemia less than 10 grams per deciliter of hemoglobin. And other factors which are related to the surgical operation, which is emergency procedure, surgical incision, and duration of surgery. If this score is higher than 26, there is an increased risk to develop a postoperative complication up to 15 to 20%. But more importantly, if this score is higher than 45, 46, you have almost a probability of 50% to develop a postoperative pulmonary complication. And these data were also prospectively validated in more than 5,000 patients in this relatively recent study performed again by the prominent investigators and the European Society of Anesthesiology. So it is a very easy score to be performed. And more importantly, the oxygen saturation in air, as you can see here, is a very important predictor of possible complication in the postoperative period. When oxygen saturation is less than 92, you see that there is a major increase up to 30-35% to develop complications. So we believe that the use of oxygen saturation measurement in air in the preoperative visit is extremely important. And this is also being found in this very recent study, the Las Vegas studies just recently published in more than 9,000 patients, almost 10,000 patients. You see here the risk of developing PPC in patients with ARISCA score less than 26 or higher than 26. You see a major difference between the two, so showing that even in this very large population, this score is very effective. And if you look at the patient at a low risk or increased risk of PPC, this is also associated with an increased risk to stay longer in the hospital, and more importantly, to have an increased risk to die. So ARISCA score seems to be very effective in the general population of patients undergoing surgery. What can we do also to prevent complication intraoperatively? And I will focus very briefly on these factors. First of all, the use of neuroaxial blockade. There's a large discussion on that. Most of the studies showed that neuroaxial blockade may reduce the risk to develop pneumonia in the postoperative period, but this appears have no effect when regional anesthesia was added to general anesthesia. So there are some controversial results related to the possible influence of regional anesthesia on reduction in postoperative pulmonary complication. This is, of course, has nothing to do to the positive influence in terms of pain control. What about volatile and intravenous anesthetics intraoperatively? As you can know, the anesthetics may have different effects on the brain, mainly on the hypothalamus and also on the sympathetic nerve, in order to modulate the response in terms of glucocorticosteroids and catecholamines, and then modulate possible immunosuppression. So we recently performed a very large meta-analysis of the data available, showing that volatile anesthetics were associated with less pulmonary complication and extrapulmonary complication in cardiac surgery. But when we look at non-cardiac surgery, there was a quite interesting trend, not significant at 0.08, but very interesting trend with a relatively low heterogeneity towards a better effect with volatile anesthetics as compared to intravenous anesthetics to prevent pulmonary and postoperative complications. So this means that this is something that has to be investigated in the large trial in the next future in the comparison between volatile and intravenous, but our data suggest that there is a interesting trend towards less complication when even in non-cardiac surgery, volatile are used instead of intravenous anesthetics. But this is not a full-powered randomized controlled trial. What about neuromuscular blocking? Again, this is the data coming from a Las Vegas study. And interestingly, as you can see here, the monitoring of neuromuscular function during surgery is very poor. It's not currently performed by most of our colleagues, and even in patients at risk of pulmonary complication, in only 25-26% of the patients. And we know the development of postoperative residual coralization was associated with an increased risk to develop PPC. And so this is something that has to be evaluated again in the next future. Hemodynamic embryomization, I will not discuss that in detail because it's a matter of a next talk. This is a meta-analysis by Rupert Pierce and colleagues showing that hemodynamic control during surgery in high-risk patients may be associated with a decreased risk of death. Interestingly, in this last year, we learned much more about the possible protection and reduction in postoperative pulmonary complication with optimization of mechanical ventilation during surgery. And to make a long story short, this is an individual data meta-analysis, including the IMPROVE study and the PROVILO study, which are the largest performed right now in more than 2,000 patients, showing that the tidal volume between 6 to 8 during surgery was associated with a reduction in the risk to develop PPC after surgery. And we also recently found and published on Lancet Respiratory that most importantly is not only tidal volume, but also driving pressure. So driving pressure, the difference between plateau pressure and PEEP value, less than 13 centimeters of water, seems to be protective against the risk to develop PPC after surgery. However, when we look at the modalities of ventilation during surgery, as you can see here, almost more than 40% of the patients are again ventilated with a tidal volume higher than 8 milliliters per kilogram. So I think we have to move more and more towards more protective ventilation during surgery, and with a particular attention to the reduction of tidal volume. What about postoperative optimization to prevent pulmonary complication? First of all, these are very recent data we published. We perform a magnetic resonance in the patients before and after abdominal surgery at high risk with open abdominal surgery. And you can see here, this is the magnetic resonance before surgery, and this is after surgery. In many patients, we did not find any evidence of any atelectasis after surgery. In some patients, we found some amount of atelectasis, which is equivalent of around 5 to 6% of the total lung volume. While in other patients, we did not find any evidence of clear atelectasis, but just amount of pleural effusion around 200, 250 milliliters, mainly in those patients in which surgery was upper abdominal surgery. So this is just to show you that the morphology of the lung after surgery, even with open abdominal surgery, may be extremely different. And this is, I think, is also interesting because if we apply, for example, CPAP or non-invasive respiratory support in all patients or only in patients at risk after surgery, it's a completely different situation if you have likely atelectasis, and we don't know, for example, if CPAP of positive pressure may be really effective to do something on this atelectasis, or it's different if you have pleural effusion. You just apply pressure here, but you don't have any effect on the lung structure. And that's why we believe that the use of echo, for example, in the postoperative period, may be important to better understand this pathophysiology. And again, these are data in preparation where we correlated the oxygenation in air after surgery and the amount of atelectasis as measured by magnetic resonance after surgery. And you see that if oxygen saturation is higher than 95 in air after surgery, you are almost sure that patients are not developing any atelectasis. If the saturation is less than 95 in air, you see that almost 50% of the patients or 60% of the patients, they have atelectasis, or perhaps these patients are more likely to have some beneficial effects on non-invasive respiratory support. But to have also a quite large number of patients with a saturation less than 95 that are not developing atelectasis. And these patients are perhaps likely not responding to non-invasive respiratory support. So this is going to emphasize the importance to improve our lung imaging technology at the bedside, probably to better define these patients from these patients according to the saturation. But other message is, again, the oxygen saturation in air after surgery, as before surgery, appears to be a very easy method and cheap method to try to have more ideas on what is going on to the lung of these patients. The question about FiO2, this is another issue, and really a little bit different from what has been suggested by the recent guidelines from the WHO. Several meta-analyses showing that there is no effect on surgical infection on higher lower perioperative FiO2, and there is also no effect of higher lower perioperative FiO2. So why to use higher FiO2 as suggested by WHO guidelines in all patients after surgery? And we recently wrote an editorial in one recent paper discussing this issue about the use of FiO2 in this patient. Personally, I think we have no evidence that we have to use higher FiO2 in all patients, and we should restrict FiO2 according, target FiO2 according to the physiological level of saturation. How to identify early patients who are going to worsen in the postoperative period? We are very interested in the use of the recently proposed quick SOFA. This was really proposed for the septic patients, which means respiratory rate higher than 22, altermentation, and systolic pressure less than 100. But I would also add, and this was not examined in this study, oxygen saturation in air less than 94. This score may be very easy to be obtained at the bedside after surgery, and it can be summarized with this acronym TAM, so tachypnea, hypertension, and altermentation. And this means that when we have a quick SOFA, a positive quick SOFA, we should probably increase the promptly perform additional tests to evaluate organ function, have a prompt intervention, and have an increased surveillance of transfer to ICU. Another parameter that I find extremely interesting that would be probably more carefully investigated is the use of NEWS, so the National Early Warning Score, to assess the acute illness severity in the ward after operation. What about physiotherapy? We know that physiotherapy may have an effect in these patients, even there is some debate about its usefulness in all patients, but mainly early mobilization, deep breathing, and incentive cuff appears to be the most important maneuver to be performed. Some doubts, there are no clear evidence that incentive spirometry per se may be helpful to improve postoperative pulmonary complication in the after surgery. Just few words about non-invasive respiratory support. There are not large data available, even if some of the data suggest in a very heterogeneous and old performance study that may be helpful to reduce the postoperative pneumonia and perhaps to a trend of hospital survival, especially when applied to patients who are developing respiratory failure. We know that this is a very recent study comparing high-flow nasal cannula with conventional oxygen therapy in hypoxemic patients after abdominal surgery. And this study did not clearly show any difference in terms of protection against PPC. So there are no clear data suggesting that in patients who are not developing respiratory failure, the early application of non-invasive respiratory support may be helpful. However, if you are going to develop early respiratory failure, so PO2 FiO2 lower than 300, some data suggest that the application of non-invasive ventilation as compared to standard oxygen therapy may be helpful to reduce intubation. So to summarize this point, I think we have evidence that if you are developing respiratory failure, non-invasive respiratory support may be helpful, but if you are not developing respiratory failure, there are no clear data, but it's open for debate, that early application of non-invasive respiratory support may be helpful to protect against PPC. So the conclusion is here, and if you are interested, these are recent reviews summarizing these issues. This is a very complex problem. We just discussed some of them, but what I think we have to be clear in our units, a clear program and clear guidelines from the preoperatively risk stratification of the patients and consider to have a plan, a mission to the PACU or the ICU, especially in subject at risk, a clear plan intraoperatively. I show you very recent data on mechanical ventilation, protective mechanical ventilation, and hemodynamic monitor in patients at risk will be discussed later. Probably we have to take care more carefully to the neuromuscular blockade, but there are some studies ongoing on this issue. And then we have to look also at the postoperative period and especially an adequate pain management, but also physiotherapy and in particular early mobilization, and probably right now to restrict the use of non-invasive respiratory support in patients who are developing respiratory failure. Thank you very much.
Thank you very much, Paolo. Any questions to the expert? None so far? Okay, Paolo, then I might ask one question just. The impact of muscle relaxant. As you know, we did this popular study, and I can say it because it only confirms previous result. We found the risk factors of RS-cut and periscope again, okay, for post-operative pulmonary complications, but the impact of muscle relaxant is huge. So if you look, for instance, on volatile anesthetics versus TIVA, which is, let's say, 0.8 or 0.9, you know, muscle relaxants double, and the Eicherman had that shown before, double the incidence of post-operative pulmonary complications.
Yes, that's why I put these slides, because I think this is something that is very much underestimated. And in fact, I show you that, that the data available shows that in operating room and also in ICU, there is not much attention, even in patient at risk. This is, to me, is very disturbing. And so it's something that we also found in Las Vegas, as confirmed in Popular, is that even the increase is almost 20% more. So it's a huge impact in the PORC or lack of reversal in terms of complication.
Reversal doesn't help. Has been shown
reversal does not help. But to follow probably the presence of PORC was associated with complication
Okay.
in the Las Vegas.
So that was a little bit frustrating looking at these data. Any other questions to Paolo? Oh, there's one. Christian?
Is there any impact or role for preoperative lung function?
Oh, yeah.
Yes. So there are some data, mainly in cardiac surgery, showing that a very well-defined preoperative physiotherapy was effective to reduce PPC.
If you're interested in that, you should look to Maastricht. In Maastricht is a professor for physiotherapy who has a BIBO program. What is BIBO? BIBO is better in, better out. He has marvelous results with preoperative physiotherapy. Much better outcomes.
Yeah. And now I know that there are, you can have a look on Google, and so on clinical trials, there are some large studies ongoing, exactly focusing on this point, so the possible role of preoperative physiotherapy. And I think, even if you have not the data available, that is something that in the next future we will have to talk with more data available. But of course, I did not address too much this issue actually, because the data are the main data restricted to some group of patients are very interesting. There are not actually large study published on that, but I am absolutely convinced that this is something that in the next future, next year, or in the next 2 years, we will have more information on that.
Okay. As we are behind our time, thank you very much,